We are going to start this series of the anatomy of the pelvis and perineum by the first part about the bony pelvis. So we'll start by the bony pelvis, by the hip bone. We'll summarize the important features which you have to know while studying the pelvis. What we can see here is the X-ray on the right side for a child. On the left side, this is the hip bone, adult hip bone. The hip bone is formed of three parts: the ilium, the pubis, and the ischium. And those three parts will meet to form the acetabular fossa here. The share is 1/5 for the pubis, 2/5 to the ilium, and 2/5 for the ischium. They meet also at the side of the pubic arch between the ischial ramus and the inferior pubic ramus. That line fusion at the acetabulum, the meeting point, will unite at the age of 14 to 16, 14 in females mainly and 16 in the male. The site of the pubic arch will unite at the age of 7 years, around 7 years of age. That is the meeting points and the age of union of these three bones together. As an adult hip bone here, it has two surfaces, outer and inner surface. The inner surface, as you will see, will be divided into two parts: iliac fossa and sacropelvic surface. Let's start by the outer surface, which we can see here. That is the gluteal surface of the ilium, and that is the upper border, which we call it the iliac crest. That is the anterior border of the ilium and the posterior border of the ilium here. We'll see the medial border when we come to the inner surface. Along the anterior border, this is the anterior superior iliac spine, and this is the anterior inferior iliac spine. Here is the posterior superior and the posterior inferior iliac spine will be shown again more clear on the inner surface. We can see here the anterior, the middle, and the posterior gluteal lines, or the anterior, the posterior, and the inferior. It can be either ways. And this is the area of origin of the gluteal muscles: the minimus, the medius, and the maximus. Here you can see the greater sciatic notch and the lesser sciatic notch with the ischial spine in between. You can see the body of the ischium and the ischial ramus. These are the two parts of the ischium. You can see the anterior border, the posterior border, and the lateral border of the body of the ischium. You can see the ischial tuberosity here, the very large tuberosity here. You can see the femoral surface and the gluteal surface of the ischium, and we'll see the pelvic surface from the other side. That is the obturator foramen here. The acetabulum, you can see the fossa, the notch, and the lunate surface, the articular surface here. Looking to the medial surface, you can see the medial border here of the inner surface, which is formed of the articular border and the arcuate line, dividing this surface into iliac fossa and sacro-pelvic surface. Sacro-pelvic surface, part for articulation with the sacrum, and part which will share in the formation of the walls of the lesser pelvis or the true pelvis. Any part on this surface here is called pelvic. So you got the pelvic surface of the pubis, the pelvic surface of the ilium, the pelvic surface of the ischium. Here, that is the sacral part which articulate with the sacrum. You can see it is divided into two main parts: an auricular surface which articulates with the sacrum to form the sacroiliac joint, the synovial part of it. Then an iliac tuberosity elevation here, which is attached to the sacrum by an interosseous ligament, and it is supposed to be a fibrous joint here. There will be an anterior sacroiliac ligament and posterior sacroiliac ligament and interosseous ligament here. That is the sacral part. That is the iliac fossa here, which give origin to the iliacus muscle. That is the anterior superior iliac spine, the anterior inferior iliac spine. That's the posterior superior iliac spine, the posterior inferior iliac spine. That's what we call it the arcuate line. That is the iliopectineal eminence or iliopubic eminence. The fusion is very clear here between the pubis and the ilium. Then this is the pectineal line, which will be continued with the pubic crest here. We'll show it on the other side. That is the greater sciatic notch again, the ischial spine, the lesser sciatic notch, the obturator foramen. On the right side, that's again the inner surface, showing the superior pubic ramus, the body of the pubis, and the inferior pubic ramus. Here you can see the surfaces and borders of the superior pubic ramus in a very clear way. That is the pectineal line, the continuation of the arcuate line, and the iliopectineal eminence here. That is the obturator crest, and that is the inferior border. It has three surfaces: a pectineal surface, an obturator surface, and the outer is the femoral surface. That is the borders and surfaces of the superior pubic ramus. The body of the pubis have a medial surface or symphysial surface, an upper border, which we call it the pubic crest. Lateral to it, this is the pubic tubercle. It has a femoral surface on the outer side, and in the inner side, on the other side, will be the pelvic surface. For the ischium, we can see the body and the ramus only. On this side, you can see also the pectineal line, which we have seen, and the inferior border of the body of the pubis. That should be the obturator crest, and this should be the pectineal surface. That is a rapid summary for the surfaces and borders of the hip bone, which are the basic just to follow when we are describing the anatomy of the pelvis and the perineum. That is the sacrum, which completes the bony pelvis posteriorly with articulation of the two hip bones on each side. When we look to the sacrum from the front, we can identify the promontory, the ala, the upper part, we should call it the base here for articulation with the fifth lumbar vertebrae, the two articular tubercles, which articulate again with the fifth lumbar. This is secondary cartilaginous joint. These two joints are synovial joints. Then a median part and two lateral masses. Sometimes they call it the wings, but these are the lateral mass, and this is the median mass here. That is the transverse lines as a result of the fusion of the 5 pieces of sacrum, which will result in some features which we can see now. The first feature is that the intervertebral foramen now have an anterior sacral foramina, usually in the vertebral column, and it is in the lateral side. But because of the fusion here, you have an anterior sacral foramina and posterior sacral foramina. The other thing is the fusion, as we said, forming the median and the two lateral masses. Below, it articulates with the coccyx, forming the sacrococcygeal joint, again a cartilaginous, secondary cartilaginous joint. In male, the sacrum is concave from end to end, but in the female, it is straight in the upper 3 pieces and become concave from the lower 2 pieces only. So it is concave from end to end in the male and straight in the upper 3 pieces, concave in the lower part of the sacrum to give space for the pelvis. Looking from the back, this is what we call it the sacral hiatus, and the upper part here will be the beginning of the sacral canal, and this is the lower part of the sacral canal, having 2 tubercles on each side of the hiatus here. This hiatus is high, and this is not normal. Usually the normal, it ends at the last piece of sacrum, but it can extend up to any level, a sort of spina bifida, but does not have a bad effects here. The union of the spines in the middle line, the fusion, will create what we call it the median sacral crest. The fusion of the articular facets will form the medial sacral crest, while fusion of the transverse processes will form the lateral sacral crest. These are the posterior sacral foramina over here. Usually, the main part which we have to take care of or to remember all the time is the contents of that sacral canal. In a summary, from outside to inside, we have the posterior longitudinal ligament on the back of the vertebrae here. This is the most outside structure. Then a space which we call it the epidural space. When it goes up this epidural space, it can be called in the vertebral canal the extradural space. It is continuous with each other. Here we can call it epidural because the dura does not go down. In that epidural space or extradural space in the whole vertebral canal, it contains semi-liquid fat which help in support of the spinal cord. And more important is the internal vertebral plexus of veins, which is a large plexus, extends from the sacral hiatus here up to the foramen magnum through the vertebral canal. It occupies this whole vertebral canal. Its main feature that it is valveless, it has no valves. The other main feature or important feature that along the course of that plexus in the spinal canal, it communicates with the plexus of veins in the pelvis, in the abdomen, in the thorax, in the neck. It's free communication, but mainly with the pelvis, because the pelvis, as we will know, has a specific feature of the venous plexuses around each organ in the pelvis. Through this communication between outside and inside the canal, infection and cancer cells can be freely communicated to the rest of the body along the vertebral column. The main organ which can do that is the prostate in the male, but other organs, the bladder, the uterus, any organ can do the same. Within the sacral epidural space here will be the lower lumbar and coccygeal nerves, the roots, the lateral sacral vessels, branches, and the median sacral vessels, branches, crossing from the anterior foramina to the posterior foramina, and some branches will enter to supply the structures within the epidural space. Next to that will be the dura mater, which will end at the level of the second sacrum, base. Second to the dura, deep to it, will be the subdural space, which is a potential space. Any contents in the subdural space, blood, fluid, pus, whatever, is a pathogenic phenomena. Deep to the subdural will be the arachnoid, again to the level of the second sacrum. Deep to it will be the subarachnoid space containing the cerebrospinal fluid and the blood vessels supplying the spinal nerves and up the spinal cord, with the roots of the upper lumbar nerves coming out from the coda equina to get exit from the anterior and the posterior sacral foramina. Next will be the filum terminal, the extension of the pia mater, which will end up to the back of the coccyx. That is the contents of the sacral canal. That's a good specimen, cadaveric specimen. showing the ligaments of the pelvis, the external ligaments or the ligaments attached to the bones. This is the sacrospinous ligament between the last piece of sacrum and the ischial spine. This is the sacrotuberous ligament extending from the medial lip of the ischial tuberosity to the back of sacrum and the coccyx, and the posterior superior and inferior iliac spines. This is the inguinal ligament, and this is the pectineal ligament over the pectineal line here, and this is the lacunar ligament, the lateral extension from the medial end of the inguinal ligament over the pectineal line. That is the lacunar ligament. That is the obturator membrane here, and this should be the obturator canal, which will transmit the obturator nerve and vessels. Clearly, this is the greater sciatic foramen, and this is the lesser sciatic foramen. That's a good specimen, or cadaveric one. Now to the planes of the pelvis, which we can see here. That is the line of inlet of the pelvis, and that is the line of outlet of the pelvis. You can see between the horizontal, the vertical plane and the inlet, there is an angle, acute angle here. Another angle between the horizontal plane and the inlet, which is almost 57 degrees here. Another angle between the outlet and the horizontal plane, which is almost 15 degrees. We know that the pelvis is tilted, is oblique during the erect position, and the points to judge this is to put the anterior superior iliac spine and the pubic tubercle at a vertical plane. It will show you the obliquity of the pelvis. In that position, which you will see now in the next figure, the pubic arch is horizontal, is not vertical as it appears in some of the diagrams. And this will depend on the orientation of many structures in the pelvis. That is the plane of the inlet here. The axis of the cavity, that is the axis of the cavity. The plane of the inlet is this one. The arrow is moved a bit. So this is the axis of the cavity of the pelvis. These are the planes of the pelvis, from the promontory to the upper border of the symphysis pubis, that is the plane of the inlet, from the lower border of the symphysis to the tip of coccyx, that's the plane of the outlet, and this is the axis of the cavity itself. These are the diameters of the pelvis, which are important in assessing the size of the pelvis during pregnancy. There is the anteroposterior diameter, or the conjugate, the transverse diameter, and the oblique diameter. These are the three diameters which usually are considered. For the conjugate diameter, either the true or the diagonal. The true is the one which is usually used in radiography, and it is between the upper border of the symphysis pubis and the sacral promontory, while the diagonal is the one used during vaginal examination between the lower border of the symphysis pubis to the promontory. The transverse diameter, which is larger in female, 125 compared to 120, this is the widest transverse diameter between the side walls of the pelvis, and this can be again measured radiologically. The oblique one, again 110 in male, 131 in female, between the lowest point of the sacroiliac joint and the opposite iliopubic or iliopectineal eminence, which is the midpoint of the opposite obturator foramen roughly. These are the diameters of the pelvis. Here is a diagram which shows these diameters. That is the transverse, that is the oblique, and that is the anteroposterior one here. Either the true conjugate or the diagonal one. Here in that diagram, you can see the pubic arch is not seen. This is the proper position of the pelvis in an erect subject. The pubic arch will be horizontal, as we said. The perineal membrane, which is stretched between the two sides, will be again horizontal, having upper surface, lower surface, anterior and posterior border. The lacunar ligament, which extend as a medial extension from lateral extension from the medial end of the inguinal ligament, will be again horizontal, so it can form the floor of the inguinal canal, and so on. So orientation of the description of the structures, especially in the perineum and the pelvis, depend on orientation of that position of the pelvis being oblique. There is some differences between the male and the female pelvises. It's almost around 13 differences counted here. But the main difference, or this difference, is the result of, if you have the pelvis, imagine you have stretched laterally to widen the pelvis to accommodate the fetus, and you compress it from above downward to make the birth canal as short as possible. Out of all of these differences will arise because of this stretching and compression. The inlet is heart-shaped in male, wider in circular in female. The pubic arch is narrow here, and the acute angle is almost obtuse angle because of the stretch. The margins of the pubic arch are everted, but here are not everted in the female. The greater sciatic notch will be narrow and deep, will be wide and shallow in the female. Ischial spines will project more in the male than in the female, and they are inverted. In the male it is inverted. Ischial tuberosity are everted, but more everted in the female. The distance between the two tubercles will be less in the male than in the female. The acetabulum will be wider in male because of the size of the bones, compared to the female will be narrow. The obturator foramen will be large and oval in the male, but will be small and triangular in the female. There is a major difference, which we call it the preauricular sulcus. If we imagine that auricle, which is the articular surface of the sacral part of the ilium, which articulate with the sacrum, Below the transverse part of this auricular surface, there is a lip where is attached the anterior sacroiliac ligament. With multiple pregnancies in the female, that lip will be stretched, creating a sulcus below it, which we call it the preauricular sulcus. In female multiparous, it can admit the tip of a little finger. So it's a very important point to differentiate between the male and the female pelvises. The sacrum, as we described in the male, concave from end to end, long and narrow. In the female, short and wide, but straight in the upper three pieces, and concave in the lower part only. Coccyx will be fixed more in the male than in female. As usual, the bones of the female are more heavier. I mean, the bones of the male are more heavier than in the female. That is a view for the female pelvis compared to the male pelvis. The inlet rounded in female, oval in male. The same thing, the outlet is rounded in female and oval in female. And sometimes we describe it as heart-shaped in the male. The romantic heart, not the real heart. Of the male and the female. That is the female one, and that is the male one here. You can notice some differences here. The broad sacrum here compared to the sacrum on the side. The promontory in relation to the ala. Here it is large in relation to the ala. The other difference which we have described about the wideness of the pelvis here, the oval or the heart-shaped over here. You can see the hip bone difference between that one and that one here. So we have described the differences, and these are two samples of the male and female pelvis.